Okay, guys, let's get started on the concept of metabolism. So, if you have your book, we are on, let's see, we are on page 785, okay? And important concept, several exemplars will be taught with this concept, but we know that metabolism is a chemical reactions that occur in the body. They help the cells produce energy, they help cells repair, just overall maintain life and homeostasis. This would be a good time for you guys to go ahead and read the beginning of the chapter, which is a nice review on anatomy and physiology. All the hormones that are released by the endocrine glands is absolutely necessary to know when we're going to study the different exemplars. Okay, so we've already been over the definition of metabolism as the chemical process that occurs within a living organism in order to maintain life. This is what we hope to accomplish while we study the concept of metabolism, looking at it from the physiology in the body, how it alters, how different alterations occur in metabolism, and therefore leads to our exemplars that we're going to study, the relationship of metabolism with the other concepts, how we can promote healthy metabolism, what type of assessment procedures and diagnostics we need to use, independent nursing actions versus collaborative actions. Okay, so we're going to get started on some of the various disorders that can happen from the fact that we have an imbalance in the hormones. And so it breaks it down into the different glands. And so, for instance, there's the pituitary. We're looking at the pituitary. If you're looking in your book on page 793, it says changes in growth. So, for instance, if you have a deficiency in the growth hormone, you'll have a child of smaller size, and we would treat that with supplying them with the growth hormone. You can have a child that has too much growth hormone. This is called gigantism, and compared to others of the same age and gender, they have larger bones, larger organs, etc. If that would carry on into adulthood, it's called acromegalia. And so again, we focus on the hormone, the growth hormone, and we would want to hopefully lower the production of this growth hormone, but then you also have to treat any negative side effects from having this disease. If you go down to the next box, changes in thirst and urinary output, it talks about the antidiuretic hormone. And so, for instance, if you have too little of the antidiuretic hormone, it results in what we call DI, or diabetes insipidus. And so DI, or diabetes insipidus, and this is an individual who just pees a lot and is really thirsty, so they have polydipsia and polyuria. And so again, we would replace them with a synthetic form of this hormone, which can be a nasal spray, it can be a tablet, it can be an injection, to help correct this problem, because this individual can get into some pretty significant fluid volume deficit issues and electrolyte imbalances. The opposite of DI is called SIADH, or the syndrome of inappropriate antidiuretic hormone. And so that would be it for the pituitary that we would be focusing on. So next it moves on to adrenals. And so actually you need to flip over to 794, and it talks about when we have an adrenal issue, it's usually because we have changes in cortisol regulation. So you have two different diseases that could result from this, and that's Addison's disease and Cushing's. We've talked a little bit about Cushing's in the classroom, but when you have too little cortisol, you have Addison's, and when you have too much, you have Cushing's. And so, for instance, you're looking at Cushy Carl here on your slide. So this is too much cortisol. And so it can be very similar to someone who has to take an outside source of steroids, that they can develop these same signs and symptoms. And so Cushy Carl, as you can see, has the moon face. He has, this truncal obesity. He has an increased susceptibility to infection, hyperglycemia. So many things that we've talked about when we take an outside source of a steroid. When we look at someone who has Addison's disease, then they have too little cortisol. And this is someone who has muscle weakness, they have weight loss and fatigue, they can have electrolyte imbalances. So in order to treat these, we would obviously either increase or decrease the amount of cortisol that they are getting. Next, when you talk about the thyroid, you're talking about the thyroid hormone. Goes back to the same thing, either overproduction or not enough production. This is one of our exemplars: hyperthyroidism, hypothyroidism, Graves' disease, which is the most common cause of hyperthyroidism. And so we will talk about this more in depth in the classroom. When you're looking at changes in calcium regulation, we've already talked a little bit about this in class. When you're looking at the parathyroid hormone, then you're looking at too much or too little, just like the other disease processes. Too much, we have hyperparathyroidism; too little, hypoparathyroidism. And so the thing about this is, then we've talked about in class that this leads to an abnormal calcium and phosphorus levels, and so that's what we really have to focus on additionally. So if you have someone who has hyperparathyroidism, too much calcium, a lot of times this individual will end up with surgical intervention for removal of the parathyroid glands, and then some pharmacological interventions, possibly hormone replacement therapy, the biphosphonates. If we need to get the calcium level down, we've talked about how to do that in class. For someone with hypoparathyroidism, then they're going to suffer from a low calcium level, so they might need to take oral calcium tablets, maybe vitamin D, encourage a diet that's rich in calcium but low in phosphorus. And then the last one that I brought attention to here is the pancreas, and the pancreas is responsible for glucose regulation. And so when we get into changes in insulin secretion, regulation, the body's ability to use the glucose wisely, then our exemplars are type 1 and type 2 diabetes, which we will spend a lengthy amount of time examining in the classroom. When we're looking at concepts that are interrelated to metabolism, really every single concept could be related to metabolism, but we look at collaboration. It makes sense because a lot of times, one, these guys have comorbidities that need to be managed. And the first one that pops in my mind is when someone has type 2 diabetes, and maybe it's the result of obesity, and so they need to see a nutritionist, they need to see an exercise specialist, and also a lot of times these disease processes that result from issues with metabolism need to see a specialist, which is usually an endocrinologist. For instance, like with hyperparathyroidism or hyperthyroidism, it could be a surgeon. And so collaboration is absolutely necessary. When you look to tie in fluid and electrolytes, it is so easy to tie into metabolism. So many of these processes, when not caught and dealt with, can lead to a fluid and electrolyte issue. So when you think about the adrenals, for instance, and their production of aldosterone, if it's too high, we know there goes sodium and water retention. We know that sodium and water retention are going to lead to fluid volume excess. And so now you have someone who is in fluid volume excess, which we've already talked about, and how to assess for. We're going to talk about liver disease and metabolism. We know that when someone develops liver disease, they have a decreased production of albumin. This decreased production of albumin can lead to fluid volume excess, especially in the sense of third spacing. And so, for instance, ascites. We can have issues, for instance, with the antidiuretic hormone. We talked about the antidiuretic hormone, not enough production, leading to diabetes insipidus, someone who's peeing a lot, and then they're going to have a fluid volume deficit. And so now you guys know how to deal with, assess for, and treat a fluid volume deficit. When you are looking, for instance, just at chronic kidney disease and, too many waste products. When you're looking at, for instance, someone who has type 1 diabetes, and when they have type 1 diabetes and it's not managed appropriately, they can go into a complication called DKA, diabetic ketoacidosis. This is someone who comes in and is severely dehydrated or has fluid volume deficit and also has electrolyte imbalances. So we could go on and on, but just realize many of the disease processes that occur with metabolism, we will talk about fluid and electrolyte issues in addition to. When we talk about mobility tying into metabolism, it ties into, for instance, the hyperparathyroidism, tying into calcium. So we know a low calcium is not good for a patient, especially an elderly patient. It can lead to low bone density and place that patient at risk for falls. When we look at perfusion, I go back to aldosterone, increased production, sodium retention, fluid retention leads to hypertension. And so this is why some of the medications that we give or prescribe for hypertension work here. We don't treat the hypertension. We continue to allow this increased production of aldosterone with the sodium and fluid retention. It leads to chronic overstretching of the ventricles, and you have someone then that leads to heart failure, and then you have a perfusion issue because your heart's not pumping effectively. And then the last one, stress and coping. This is really important, for instance, in the disease Addison's. You know, when they have poor cortisol production in the first place, and so then they get into a stressful situation. It could be emotional, it could be physiological, such as surgery. Then their body is not able to produce the amount of cortisol that they need in order to respond to that stressor, and they can actually go into what we call an Addisonian crisis. When we're looking at prevalence of the disorders related to metabolism, you can go back in your book to page 792. The first thing it talks about is diabetes. It talks about the fact that there are millions. It says 21 million individuals with diabetes. The majority of these individuals, 90% or greater, have type 2 diabetes. And that leads us into obesity, which is an all-time high in the United States, and we know this. And so it talks about the high incidence of obesity in the United States and how we have that rising population of what we consider extremely obese. When you look at thyroid disorders, you can see that they're certainly not as common. Hypothyroidism is a little bit more common than hyper, and we know that the most common cause of hyperthyroidism is Graves' disease. When you look at Addison's and Cushing's, you can see why we're not going to spend a great amount of time on these two particular diseases. They're rare. And then you get into cirrhosis, and it says, liver cirrhosis is a major cause of death in the United States. We can take this back to the leading causes of liver disease, which in the United States are alcohol related and getting Hep B or C. Genetics really vary in the metabolic disorders. Not as quite a common thread as some of the other disorders that we've already talked about. For instance, like with type 1 diabetes, your child has a higher incidence of getting type 1 if you are a type 1 diabetic, but there are not a lot of genetic ties to the other disorders that we're going to discuss in metabolism. You guys understand the non-modifiable risk factors. And then, of course, we always have the modifiable risk factors. And, they're numerous when we're looking at these because, in this particular concept, we're studying the exemplars of type 2 diabetes and obesity. And so when we're looking at modifiable risk factors, just from that standpoint, then we know that a sedentary lifestyle, a diet that's high in calories, carbs, and fats is not good. When we look at the consumption of alcohol, we know that that is the leading cause of liver disease and cirrhosis, so we would need to focus on that. We know that you can have modifiable risk factors, for instance, when we look at taking medications for hypothyroidism, you are then at risk for developing hyperthyroidism. When we look at, and we've already talked about this in class, long-term steroid use, then you are at risk for developing Cushing's. And then I want to bring your attention to the patient teaching section on page 796, and it talks about, in general, just hormone replacement therapy. And this is certainly a modifiable risk factor. If you, for instance, do not take your thyroid hormone because you have a thyroid disease, then you're going to end up with muscle weakness, depression, weight gain. all the other signs and symptoms related to hypothyroidism. You could even end up in a coma. And so you have to realize that hormone replacement therapy for hypothyroidism is lifelong. It talks about taking corticosteroids for adrenal insufficiency or Addison's disease. If you do not take these replacement hormones, then you could end up in a life-threatening crisis called an Addisonian crisis. And last would be type 1 diabetes. Insulin replacement is a daily management, and if we do not take our insulin, we're going to result in hyperglycemia and maybe even in what we call diabetic ketoacidosis. Okay, diagnostics for metabolism. First, I broke them down into those that we would actually focus on for diabetes. So let's say that you're 45 years or older. You should be checked for diabetes and should be checked about every 3 years. You have labs and your fasting comes back. It's greater than 100 but less than 126, so greater than 100 but less than 126, then that's considered prediabetes. Maybe in the same blood draw there was the hemoglobin A1C, and so for the hemoglobin A1C, a reading of like 5.7 to 6.4% is considered pre-diabetes. Possibly they would add a glucose tolerance test. This is done, you come in, you're fasting, you drink a lot of carbs, it's a glucose solution. They check your sugar at 1 hour and 2 hours. And if, for instance, at 2 hours, your blood sugar is between 140 to 199, then you're considered prediabetes. And so this is where we would focus on lifestyle modifications that we just talked about, focusing on diet and exercise. But we would also then use the same test for the diagnosis of actual type 1, type 2 diabetes. And so, for instance, if you come in and your fasting is greater than 126, then you could be considered diabetic, but they're obviously going to focus on what is your hemoglobin A1C. The beauty of the hemoglobin A1C is it gives us a snapshot of your average daily blood sugar level for the past 3 months. And so when it gets greater than 6.4, you're going to be classified as a diabetic. And so then it just becomes a matter of who you are and is this type 1 or type 2 diabetes. Next we get into some hormone levels. And so for instance, when we're looking at, we're going to do the exemplar of thyroid disease, then we certainly are looking at the thyroid hormone, we're looking at the thyroid stimulating hormone, and we're looking at T3 and T4 levels, and these are all blood draws. You can also look at the parathyroid hormone. Obviously, moving on, we would want to look at electrolytes. Sometimes this alerts us to the fact that there's a parathyroid issue because the calcium and the phosphorus have abnormal levels. We're going to talk about the exemplar of liver disease. So certainly when we talk about liver disease, there's many diagnostics that you could do. For instance, let's say that we believe that your liver disease is related due to the fact that you have Hep B or C, then we would go on to do your liver enzymes, your AST, your ALT, your LDH. But when we're looking at someone who has a liver disease, we also then would need to look at the bilirubin, and we would need to look at the serum albumin levels. Other individual hormones, you can, for instance, learn about mother-baby. And, just from like the standpoint of the diagnosis of pregnancy. And you can understand that we would measure growth hormones, for instance, if someone had a pituitary disorder, such as the gigantism or the acromegaly. So there's many different hormone levels that could be measured. And then we also talked about the measurement of the electrolytes or the BMP. So like the BMP, remember, is the basic metabolic panel. When someone has Addison's and Cushing's, it's extremely important to monitor the BMP. We know in Cushing's, for instance, you can have a high sodium, a low potassium, you can have issues with your blood sugar being elevated, and so we would need to monitor that closely. So really the diagnostics are very particular to the metabolic disorder that the patient is suspected of having. When we talk about nursing assessment for someone who has a metabolic disorder, there's numerous things that we need to look at. You certainly need to pay attention to the patient's chief complaint. It could be related to weight. It could be related that they've gained too much weight or they've lost weight, that their energy level's over the top or their energy level is really poor, that they've had a change in their skin appearance, their hair, their nails. So there's so many things that we need to look at and assess. Your book doesn't mention skin, but I wanted to start with skin, hair, and nails because that's extremely important, especially for disorders of the thyroid, the liver, also for Addison's, and Cushing's for that matter. And so when you're looking at the skin, you want to look to see if there's been a change in the appearance. Are there new lesions? For instance, someone with liver disease could have easy bruising. They could have what we call spider angiomas. They could have what we call petechiae. Petechiae are just little hemorrhages. Is the skin excessively dry, oily, rough, scaly? The same goes for the nails. Are the nails thick? Are they brittle? Is the hair brittle? Is the hair thin? The skin tone, for instance, in Addison's, you can have some changing in the coloring, for instance, of the hands. So there's many different things as far as skin, nail, and hair assessment. If you guys look on page 799 in your book, then it talks about checking for symmetry of the face, and we know that it should be symmetrical, but there could be an abnormality when someone has too little or too much of the growth hormone. It talks about inspecting the position of the eyes, and we know for untreated hyperthyroidism that these patients can develop what we call exophthalmos, which is protrusion of the eyes. If you've not seen this before, I would encourage you to actually look it up. And this can be very difficult to deal with hyperthyroidism. It then talks about assessment of the thyroid gland. We know that the thyroid gland is the only palpable endocrine gland, but it is not usually palpable, only if there's an abnormality. And so you can see that the practitioner is standing behind the patient, placing their fingertips along where the thyroid gland is and asking the patient to swallow, making sure that if they do feel the lobes, that they feel smooth and rubbery and that there's no irregularities in the borders of the thyroid gland. If you then turn the page to 800, it talks about motor assessment. It talks about the importance of deep tendon reflexes. This is particularly true of someone who's experiencing disorders of the thyroid and the parathyroid gland. It talks about assessing sensory function. You guys learned this in the first semester. A patient's sensitivity to touch, to pain, to vibration, to light. And so you guys can read through that. It goes on to talk about just inspecting the musculoskeletal system, making sure that everything is equal in proportion. And again, this goes back to potential issues with the growth hormone. And then last but not least, it talks about assessing for hypocalcemia. And the good news is that we have already done this in class. When we look at independent nursing interventions for metabolism, you are looking at a concept that requires a tremendous amount of patient education. So first of all, these individuals a lot of time face multiple diagnostic tests that you're going to need to explain why they're doing them, what the test consists of, and then the results. And we've already talked about some of the blood tests that can be done for metabolic disorders, but no, often some metabolic disorders you have a issue with the hormone because of a tumor, and so there's more extensive testing that needs to be done. Once they are diagnosed, for instance, like with hyperthyroidism, there are multiple things that the patient needs to understand about the disease. And then not only do they need to understand about the disease itself and why they're having the signs and symptoms that they have, but they need to understand about the medication that they're going to be given. And so for hyperthyroidism, it can be management of the fact the patient's extremely tachycardic and we place them on a beta blocker to lower the heart rate. It also helps with the anxiety they feel with hyperthyroidism. So then you're educating them about a beta blocker. There's also medicines that can be used to treat the hyperthyroidism, and often we move into where they're going to have a procedure, a radiology procedure that actually destroys part of the thyroid, and then the next thing you know, once we do that, if we overshoot it, they become hypothyroid, and you're educating them about hormone replacement therapy that they have to take for the rest of their life. There's education on lifestyle modifications. When we talk about the exemplar, for instance, of liver disease, we need to talk about risky behavior for the development of Hep B and C. We need to talk to patients about the Hep B vaccine. We need to talk to patients about obesity, change in exercise, change in diet, and that also trickles into type 2 diabetes. So there is a lot of opportunity in speaking to our patients about changing modifiable risk factors. When we look at collaborative therapy, we've already talked about how extensive diagnostic testing could be, but also you have to realize, for instance, if someone is diagnosed with type 2 diabetes, then we have to go through a diagnostic process where we need to identify any comorbidities that possibly they've developed from the type 2 diabetes. When we look at medications, you have to realize, as we've already talked about, hormone replacement therapy can be for life, and so that's extremely important. I think about that when I think of someone who's taken hormone replacement therapy for type 1 diabetes and for hypothyroidism. There's also other medications that can be given just for a protective factor, and we've talked about this. For instance, like with type 2 diabetes, then we're concerned about what? They're going to develop chronic renal failure, so a lot of times they're placed on an ACE inhibitor that will require patient education. And why? Because it's unusual for them to be placed on what they would see as blood pressure, that's a medicine that's used to treat high blood pressure. Medication-wise, a lot of these meds we're going to cover in class, and they're on page 803. So if you turn to 803, you can see, for instance, there's the insulins, the oral glucose meds, the anti-thyroid agents, the calciums, and on the back you can see the parathyroid hormones. The one that we haven't talked about that I wanted to bring your attention to was the biphosphonates, which we use for osteoporosis, and because they're quite common. And you can see that they all end in dronate. So there's the aldronate. And these guys help with bone reabsorption, and they're used to treat osteoporosis. And hopefully that helps with the prevention of bone breakdown and the prevention of fractures. And so some things that you need to know about the biphosphonates are, for instance, that they should be taken on an empty stomach first thing in the morning, and the patient should remain upright for 30 minutes, and that they should not eat or drink anything else for 30 minutes, and that they need to not be taken with calcium and vitamin D. And they can have some bad GI side effects, and so that's the whole remaining upright. And so those are the biphosphonates, and those are one particular class of drugs that we're not going to talk about for any of the exemplars, but it's important for you guys to know because they are the mainstay of treatment for osteoporosis. And then we get into follow-up. Well, these metabolic disorders typically require lifelong follow-up, okay? And so they have to understand, for instance, with type 1 diabetes, there's constant monitoring of your blood glucose level daily. And for instance, with hypothyroidism and you're taking the replacement hormone, then there's going to be frequent blood monitoring to make sure that your level is sufficient. And sometimes there's been surgical intervention. For instance, if there's a tumor on the thyroid or the parathyroid has to be removed, then you're going to have follow-up because you've had surgery. So follow-up is and can be for life with many of the metabolic disorders. Lifespan considerations for certainly in the infant population, we want to do an extensive family history. We want to review if there's any concerns about genetics and leading to any of the metabolic disorders. We want to identify if there's any family history of type 1 diabetes in the parents. For children, we know that the thyroid gland's not palpable, so if for some reason it became palpable, we would certainly need to follow up on that abnormality. Most alterations in metabolism in children are genetic or congenital in nature, and we would need to follow up on these. Could be related to the presence of a tumor. We also understand that childhood obesity is on the rise and that we need to identify this and intervene early. As far as the aging adult, main concerns for metabolic disorders is the development of hypothyroidism, type 2 diabetes, and osteoporosis. Okay, so that's a wrap for the concept of metabolism. Time to rest and then review the exemplars in class. Any questions regarding this video, you guys know where to find me at pcdfodder@hccfl.edu. Have a great day, guys.